I inject myostat. Okay? Because when you take it out, you pull your probe out of the eye at this point, the iris will come out again. So what I did, I put myostat from the other wound and wait for a while until it constricts and you come out. Yeah, then you get a nice iris, nice pupil, round pupil, and with IOL inside. And then you hydrate the wound as usual. Then that's it. As opposed to the next video, I erased the surgeon's name. This is done by one of my trainees. So apparently the wound is very short. It's just like straight, one planar, one plane, very short tunnel wound. Okay? So this is what happened. So remember yesterday when we talked about how to hydrate that site, I advised to lift up the CCC and lift up the wound and let everything come out. But with this forceful dissection, it will push the iris out. Okay? And you see the wound is very short tunnel. So avoid doing this, because the iris will just come out. So what do we do with this? So the iris come out, so let's see what she did. So you don't push this using your iris repositor. What she tried to do is, she tried to use IA probe. Okay? This is quite okay, but you look at the way the IA probe is inserted. Okay, right? It's wrongly inserted. It's inserted within the iris. Okay? It causes trauma to the iris. So, continue. Okay, as compared to the earlier slide, I would have reposited this using Sinsky before I insert Phaco probe. This is Phaco probe. You can actually advise to just do once in and once out, okay? And you see what happened. Okay. This is Sinsky. She tried to chop. Right? Can you see iris come out? Is the way the probe is held is wrong. Is the wrong way of holding or introducing the Phaco probe inside the eye. Is not radial. So you see what she did. She inject viscoelastic with the hope that iris will come in, will go in. So it causes trauma to the iris. So Phaco continues. So I don't know what happened then. So the Phaco probe was taken out. It's multiple in out. Right? So again, goes in. Again, come out. Okay? Again, come out. So the lesson learned from here is when the wound construction has to be very good. You have to have enough length of tunnel as much as possible to a square shape tunnel for iris for floppy iris, and don't go in and out too frequent. And I don't know about other surgeon, but I never use iris repositor because I believe iris repositor will further damage the iris. Once it's damaged, it will just keep coming out. So better to reposit it from AC, from inside, indirect repositioning of iris. Right, I go to next. This is for the sake of yesterday's presentation. I think what happened in the morning, it's lagging. I just want to show 3 slides from yesterday. It's going to be very fast. This is what we normally do when there's an iris prolapse. This is what happens when your side port is too big. So you reposit from inside. Okay? It causes less trauma to the iris. You continue. And this is the second patient. Okay. Okay, you look at how the wound is constructed. This is done by one of my trainees. So this is, you see how the fluid comes out. You see how the wound was pressed and the fluid comes out. Yes, you see it's shallow. So what he tried to do is, he put viscoelastic in. This is a reflex response to deepen the AC before he could proceed with the second wound. So using the same blade, he tried to create a second port. Okay. Okay, struggled a bit, but managed to do. Oh, okay. Sorry. I repeat. Okay. So, okay. Oh, sorry. Okay. After the second part, he tries to proceed. Okay. Injecting vision blue because this is a dense cataract. So what happened is the vision blue is not distributed because of viscoelastic inside. So what happened is he tried to aspirate the OVD, then re-inject the vision blue. Okay. Right, finish with this, and this is the last one. And the main wound, we struggle a bit because I think it's a bit blunt. So it's done. So what happened is the second part is too anterior because I think patient move a bit. So that is too anterior. So what happened is it struggle because of the blade is a bit blunt. Okay. So we get the whole length of the whole width of the wound. So in this case, what he actually needed to do is to, when he noticed this is a bit too blunt, change it to a sharper blade, or use a 15-degree blade to create a wound. So in this case, what he can do next is to create new wound using 15 degree. I think I finished this wound. I pass this back to Madiha.
Assalamualaikum and very good morning to everybody. Okay, my presentation is a bit different from Dr. Aziz and Dr. Azura. I'll be sharing a few of the YouTube videos for better understanding. Okay, I'll be given the task to give tips and tricks on hydrodissection. Then I'll continue my presentation with some tips and tricks of doing divide and conquer in emulsification. Okay, this is my topic presented today. So in my divide and conquer techniques, I will talk a bit on cracking the nucleus, followed by irrigation and aspiration, viscoelastic removal, and wound closure. Okay, as we know, hydrodissection followed by hydrodelination is a very important step for us to proceed to finish our eco-emulsification. So hydrodissection itself is a separation of the anterior capsule from the cortex. So we have the tips is actually before we start to do the injection of the BSS in between the capsules and the cortex itself, we have to reduce the pressure in the anterior chamber first because this is very important. How do you do it? Actually, you just have to press your main posterior lip a bit. So let go of your amount of your viscoelastic. So you have actually soften your eyeball a bit. Okay. You can actually a slow gush of BSS with the minimal amounts of volume is actually preferred rather than to do a vigorous and hard gush of injecting the BSS. So you have to have an adequate BSS injection. And our aim is to create a separation and make sure that the nucleus is rotated well. So after that, you can have an easy removal of the nucleus lens itself and followed by the cortical matter. So hydrodissection is best completed by doing a hydrodelination. Okay, how to do a slow, a minimal fluid technique. Okay, we have to create a low hydrostatic pressure where we build up a precise kinetic movement. With time, we actually have the guts of doing it. So with a volume of about 2.2 mils of BSS, that actually prepared in a 1 mil syringe. Some actually prepared in a 3 mil syringe. So with a cannula of 27 gauge, we actually introduce the cannula into the anterior chamber, go to the anterior capsule and slightly lifting up the CCC just to make sure that you are at the right angle between the anterior capsule and the lens itself. Okay, then you inject your BSS with a good generating force, good enough so that you can see a fluid wave that pass across the posterior aspect of the lens. Okay, usually will stop when you actually about 3/4 of the posterior lens itself. Okay, around the equator area. Then you actually gently press the lens down in order to force out the excess fluid that actually contained at the posterior back of the lens. Okay, this is how the flow of your fluid is put in a diagram manner. So when you inject your BSS at the edge of your CCC here, so this cannula actually in between your CCC and you have to imagine that it's actually underneath the anterior capsule. So when you actually inject your BSS, you can see a flow. You have to see a flow in this type of density of immature cataract. You can see a very good flow that is going at the back of the anterior posterior back of the lens. Okay, there's one video that I want to share. I hope I can play it. The cheese part of doing hydrodissection. Now I will actually continue the second part of the talk where I'm going to give some tips and tricks how to do eco-emulsification when you actually decided to do it in a divide and conquer manner. But it's the important thing in divide and conquer is how do you want to crack the nucleus. Okay. Yesterday I already explained that you have to have a good trench, okay, which a depth of about 50 to 80%, about 3 times the width of your Phaco tips, or uniformly brighter red reflex that you can be appreciated. So when you have this type of two trenches, it means that you're already okay and can proceed to do your cracking. Okay, how do you do it? You gently go down slope and up slope in a bowling manner. So when you already have a very good trench, you bring both your Phaco tips and tips of the second instrument at the base of the trench, not at the upper part of the trench. Okay. So with a direct or in a cross manner, you just give a lateral force to the wall of the trench and crack the nucleus sideways. Okay. Some surgeon will crack it into just a heminucleus portion and start in a soft cataract, can start doing your corneal removal after that. While doing sculpting, okay, the tip is to have a shallow bite during Phaco stroke, because when you actually dump and embedded your Phaco tips too deep inside your nucleus, you might not proceed the your grooving well. Okay, you're stuck there, and it further will push the lens downwards and forward. It's not good because you're actually rocking the nucleus. Okay, try to avoid that. So start with shallow bite first. When you already have a good trench, then you follow the linear line of your trench. So widening the trench, sometimes when you will find that when you try to go in further to deepen your trench, you find I cannot go more. Why I cannot go more? It's because the sleeve or the tip stuck at a certain level when you are sometimes dealing with your more denser cataract. So try to widen your trench so you can go in further. Okay. The most important thing, please reset your Phaco power according to your density of your nucleus. If not, it's a bit difficult to emancipate your nucleus. Okay, with this diagram, you can see that in the A probe, you can see the tip of the Phaco probe is actually stuck at the level where the sleeve is there. Okay, because you cannot go further. So in that manner, you just widen a bit your trench left and right. Then you can continue doing your sculpting. And the next slide will show to you is same slide as yesterday. You place both your instrument at the base of the lens and then start cracking. Okay, as this photo shows, if you place both your instrument at the superior part of the nucleus, whereby you already make a very good trench up to the base of the lens nucleus, but your technique is wrong, you are not able to crack your nucleus until the base. And then you have difficulty to, you can rotate because you are already good, did a good, very good hydrodissection, but you are not able to Phaco out the segment of the nucleus. Okay. After cracking, we good cracking, remove the segments. We follow by irrigation and aspiration. Okay. Removing the segments of the nucleus is more or less a bit easy if you can actually crack your nucleus into 4 quadrants, and then actually in between the emulsification, you can actually further slice your nucleus into small fragments to easy emulsifying the materials. Okay, just be careful the tips when you actually taking out your last fragment, because at that particular time you really have to look at like your parameters, your vacuum and your bottle height. Your eyes have to always be at your nucleus fragment and the posterior capsule itself. See how do your posterior capsule behave. If you have an unstable anterior chamber, then you have to really careful, because you can see that your posterior capsule is always come to your pulse. Okay, in that manner, then you have to ask your partners to please reduce some of the parameters just to protect your posterior capsule. Okay, then you proceed for irrigation and aspiration. Make sure that pore is always under your visualization because the culprit in irrigation and aspiration is your position of your pot. Sometimes beginners doesn't really matters where the pot is sideways, downwards facing the PC. Okay, this is very dangerous. So always are. Unless a certain a maneuver you want it to be facing the posterior capsule. Okay, so you can either doing your irrigation and aspiration in coaxial manner or bimanual manner, or also you doing manually with your Synco Pro. Okay. As for beginners, they always prefer uh, to do the irrigation and aspiration under continuous mode. Okay, later on you should actually convert yourself not to do a continuous irrigation because you can actually reduce your damage to your endothelial area. Okay, bimanual's IA is actually have its own advantage because you have an easy access of the residual cortex, especially at the subintestinal cortex. You can actually introduce your cannula left and right, the right taking out the left cortical matter and vice versa. So, but the important part that everybody have a problem in the subintestinal cortex is it become more difficult when you have a small CCC, okay, because you have a difficult time till tilting your tips of your IA probe to catch your cortical fibers. So by manual IA, is only a direct introduction of your cannula reaching your cortical fiber and then aspirating. Okay, another tips. When you try to engage your activator at the peripheral area, at the activator area, and you already pull it into the center, and you guess you have some resistance. 2-3 times you actually try to pull it into the center, you felt resistant. Please don't continuously pulling the fibers because sometimes the attachment is still strong. Okay, you just irrigate a bit with your existing irrigation and try to re-engage again. Okay, this is to provide your zonular weakness. Don't too harsh on your cortical fibers. Okay, if it's engaged and easily come to the center, that is your aim. Okay, and another tips, make sure your cortical fiber is at the center of the iris plane already. Then you start pressing your pedal of step 3. Okay, avoid using your position of step 3 under the iris when you engaging your cortical fibers because at this particular visualization, you didn't know whether you are catching your fiber or actually you are catching your anterior capsule or even you are actually at the end of the back that is very near to your zonal area. Okay. Then it is advisable to remove your cortical fiber at the inferior quadrant first and do your subintestinal cortex later. But last but not least, some cortical matter did adhere on your posterior capsule. Then you lower down your parameter of vacuum and water height, asking for mode of polishing the back. Then you do the polishing with a gentle irrigation and aspiration. Okay, this is some diagram showing that the first you are removing your inferior quadrant, and then lastly your subincisional cortical method. Okay, at the new stage. So usually also we prefer when we have continuous iris prolapse during our coaxial irrigation and aspiration. So in a case where we got a runaway of CCC, because we want to have a less pressure to the back so that the CCC is not extended further. When we have too leaky wound due to poor wound construction, because the AC is not stable, so we might have a problem of the PCs keep on coming to the front. Okay, so in some floppy iris syndromes, yeah, sometimes it's very, very bad. the iris keep on coming out. So is whereby the manual oil is very helpful. So in some case of small pupil, okay, you cannot visualize fully where's your cortical fibers are. Okay, so in this case, manual eye is a bit safer procedure to be done. Okay, um, we can when we do a coaxial IA, sometimes it's very difficult to get out the subscenic cortex. So with manual IA, sometimes this can be done through your cycled wound. But the only disadvantage is you have to enlarge your cycled wound. Later on, might come with another problem of leaking. Okay. How about viscoelastic removal? So, at the end of the surgery, after you have completed removing your cortical matter, we have to remove the viscoelastic. We cannot actually keep the viscoelastic in the anterior chamber. We know why, because the RFP will be compromised post-operatively, and it will only be dissipated after 3 days. But it will be more in some type of viscoelastic. That's why you have to know what type of viscoelastic that you use. There is some viscoelastic as are visco-dispersive, some are visco-cohesive. So the one that is visco-cohesive need more manipulation to take it out. Okay, so you can actually achieve it by irrigate a bit of BSS from the main wound, actually flush it out if you start behind the lens. With the eye probe itself, you can tilting your IOL a bit vertical, but not too much, and then go behind the lens and start the aspiration of the viscoelastic. Usually, we will make sure that the port is always up. Okay. So the aim of your viscoelastic removal is extraction of the posterior capsule, and when your intraocular pressure is decreasing, back to normal. Okay, lastly is your wound closure. Wound closure is very important. Everything depends on how good you did your wound construction. If your wound construction from the start is actually at fault, we will encounter a lot of problems. Okay, so if you have a good wound construction, either it's with plana or triplana, so a proper hydration of the corneal stroma is very good enough to seal off your wound. Okay. Okay. In some condition, you have to enlarge your main wound just to implant your lens. That cannot be done either by docking or the cartridge is too big. Never mind, you can enlarge your wound, and the fix is just suture the main wound if you cannot hide it well. Okay. The other problem when doing wound closure is your cannula of your BSS for your hydration is sometimes got stick from its attachment of the syringe. So how to avoid this? You have to counter check this cannula is very tight enough attached to the syringe, and when you inject your BSS to hydrate the stroma, practice it to pull at the base of the canal each time when you injecting. Okay. And try to avoid pointing the BSS tips towards the posterior segment. Sometimes we never know, the cannula can still slip off, and then it will inject further your iris, leads to iris bleeding, and then sometimes it gets punctured through and then damage your posterior capsule, and sometimes even if it's rare, it can cause a retinal detachment. Okay. How about parasympathesis wound? Most of the time, the parasympathesis wound no need hydration. Okay, but it's a self-seal by itself. Okay, I think with that I thank you. Thank you very much, Dr. Azura. After this, we will proceed with Dr. Aziz, who will explain on the multiple chart techniques.
Sure. This is how I do. Okay, let's start with this. And let's do plus. Okay, right? As usual, wood, OBD in fully, and CCC. This is 2.75 wood. So the tip of getting well round is you look at the wood. I hardly create any stride. You don't drag your wood. You follow, it is a pivot within the wood. See, there's no stride at all. And you keep pulling it in. Pull in. Get the CCC without line. Make sure it's complete. I lift up the CCC edge. I lift up the just now. The full weight, two sides. Your front and back. I use small gauge probe. I use 2.75 speed. Please know. I would like you to see the size of the probe. It's 2.2 using 2.4 speed. So you have lots of irrigation coming in, and there's the likelihood of hitting, hit up is so much less using small probe. Can you hear me?
I'm sorry, Dr. Aziz. I think we can't really hear you. Yeah.
Hold on, I repeat.
Um.
Unmute. Okay. So sorry.
Unmute. So sorry lah, hiccup our presentation today. Okay, I repeat. I present using this. I present using my brother.
Okay,
start.
again.
Okay, and just forward.
Okay.
Okay, as usual, OBD. CCC. There to get CCC is not to create or not to drag your wood and pull it in all the time. I forward, right? Right, make it complete. And hydrodissection, I lift up the edge of the CCC. What is that? Voice. Okay. Then I would like you to see the probe. It's a small probe, 2.2, using 2.4 sleeve. And bevel up. Then I create a small seed key to chop. Small deep groove.
And I would like you
to see the movement of the probe within the sleeve. Right? When I clear this up, so the sleeve doesn't move. It's friendly to your wound. So clear it up because I want to see the nucleus before I rotate. Yeah. All using Sinski, rotate 180 degrees, and start chopping. So you hold within the nucleus. You hold the nucleus well. This machine is using ellipsoid. Right? It's not torsional. It's not Ozil as Centurion or Infinity. So you hold it, hold the nucleus. You vertically chop using Sinski. So you chop into 2 segments first, hemi segments, until you see PC. So you make the chop complete. Okay, and then third, to make the multiple chops. I'm still trying to develop this technique using this small gauge Phaco probe. Ideally, you should be able to chop into multiple pieces, 6 to 8 pieces in one hemi segment. The reason is we want to reduce the Phaco power. We don't want to compromise the capsule. In the next slide, I will show you how this technique can actually help to help your Phaco in doing surgery with extended CCC. So multiple vertical slices. Same with the other half segment. Then you start removing the segments. I'm still chopping the other quarter. Just chop it as thinner as possible. So you start taking it out. See the segment collapse into the Phaco probe. Okay? It's effortlessly coming to the probe with minimum Phaco power used. So you can actually help by chopping it, by slicing it horizontally using the shaft of the Sinski. But you can see the movement because it is small, it comes in small slices. You don't need to actually move your Phaco probe to catch it, or you don't need to even use your Sinski to move it. It will just come flying to your Phaco probe. It's very safe, it's very friendly to the capsule. And you actually use minimum Phaco power. Right, this is in the presence of a normal capsule. I'll show you this. I showed one yesterday, but this is a bit clearer. So this is done by a trainee to cover when it's an extension of CCC. Extended. Try to salvage this. Traditionally, I think, and actually safer if you are in training, if you are just a beginner, to actually convert to ECC. Okay? So, but when you have someone who can actually do it for you, to bail you out, try to do it. It's worth doing it rather than doing ECC. So I just want to demonstrate this technique in the presence of extended CCC. So you get, so when leader try to create a sufficient size CCC for remover, and not to stress the capsule. Right? Don't normally rotate, but with a presence of compromised capsule, I'll just try to rotate, just make sure it moves. Same thing. Is trying to do the nucleus, because I think the only time that you actually stress the back is when you are actually grooving. When you're grooving quickly, small incision, a small groove. Try to make it minimal. So how much to do, how deep to go in this compromised capsule, do as minimum as possible. So as long as you can actually hold, you feel that you can hold the nucleus, enough. So what you do, you clear cortex, you rotate. And throughout the stage, right, the stages, you don't actually compromise the capsule at all, right? This is very, the CC is already extended. Same thing, it's standardized technique. You hold. This is hard, actually hard nucleus. Try to clear. I rotate many times. Sorry, I forward skid. Okay. Okay. Hold. This is chop. Phaco potty. Then you turn to vacuum quickly. Then you can see it. Okay, what I mean by yesterday rotation, right? So I actually rotate. Can you see my left the Sinski actually rotating the segment within the back? I don't pull it in opposite direction. So can you see it's dialing until I can detach the base. So same thing, small little pieces, small little pieces. Small bigger slices. Forward. I hardly go beyond CCCH. I hardly go beyond iris. You can actually see your Sinski tip all the time during your Phaco surgery. So, horizontal slice, you slice, everything becomes small, it will fly to you. Right, this is horizontal slicing using the shaft. Why I don't use tip of the Sinski is because when I use tip of Sinski, the chop will not be complete. It's a partial chop. So the movement of the segment within the AC will be abnormal. So when I use shaft, it will be a complete chop. So it will just fly away and come to your probe. It's all shaft of the Sinski. Shaft, yeah? This is not feeding the segment to the probe. This is actually fracturing the segment. Right? And again, good tip in Phaco is to move your left hand rather than moving your right hand. So you practically try to paralyze your Phaco. You just stay there waiting to eat the segment, to consider to remove the segment. But the most active segment, your primary instrument is your left instrument. It's done. There's no extension. It's very safe. So I let my trainee took over again to insert IOL. It is safe. Yeah. So how do you compare that when you have to convert to ECC? Yeah. So that's the difference. But my advice is, when you're a beginner, you don't do this without guidance, or let somebody else do it for you. Okay, because the CCC can just extend posteriorly, and you can have nucleus drop. Okay, I finish on my 2 cases. So thanks, Maria. Stop sharing it. Mute.
Okay, thank you very much. We are so grateful actually today for having 3 senior surgeons with us. And thank you, Dr. Azura, for actually lending your time to us. Okay, I will start with wound. All right, so Dr. Aziz, how would you actually, can you give us a tip on to about minimizing decimate tear when, is there any good wound construction to minimize decimate tear during our Phaco?
Okay, my own laptop, senang. You have to make sure the eyeball is formed before you create the wound. And don't press when you are so anxious. Don't press. Try to cool down. Try to do it well. Don't press the wound. I think that pressing the wound is the key point, the culprit. When you have this decimate. Azura, what do you think?
Okay. Yeah, Aziz, thank you, Aziz. Basically, I think when we construct the wound, usually it becomes like a 2-step, okay? We try to avoid a single step and we hardly do like a 3-step wound, okay? So basically, when you have like a 2-step wound, in your route to become better surgeons, you tend to actually know and appreciate not to press on the posterior lip, because you will get egression of aqueous and a shallow anterior chamber and iris prolapse. Okay, so during your learning curve, then in order not to be too posterior, then you are a bit too anterior. So remember the wound as being a 3D construction. So you have an anterior lip and a posterior lip. So your decimates would actually be just underneath, okay? So you need to be neutral and there's no friction on either anterior and posterior, okay? So basically, sometimes with a lot of friction, the posterior lip is very thin, okay? So usually with our step wound at the internal lip, the posterior lip is the thinnest, right? So if too many friction, then that's why you see at the end of the session, during the stromal hydration of the wound, you can actually see a split. Okay, my advice is, in your next few cases, just see the more neutral you are on entry, and usually people forget when they come out of the eye after certain procedures. You feel like, oh, what's a relief, it's done, you know. So that's the usual culprit. So in the videos that Dr. Aziz have shared during the clips where the master trainees were doing, all blunders actually happen when we want to come out of the eye, and the stress is mainly on the posterior lip. Okay, so accumulation of that, you get the split of the decimates. Sometimes everything went perfect, you over stromal hydrate the wound during closure. So that itself can actually stress your wound. Okay, so just do what is adequate.
I find that when closing, during wound closure, sometimes hydration at the site is not adequate to actually close the wound. But I follow this. Sometimes I follow this surgeon from Thailand that he actually hydrate at the center. But some told me that it's actually bad to hydrate at the center because it can actually separate your decimate. Any comments from the panel? Any
You
comments?
mean the center superior, you create another wound superior to it and hydrate. Is that what you mean?
No, no.
No, it's just
The center.
hydrate at the center of the wound.
Yeah.
That
Yes.
actually
I've
close
never done that.
quite well. Yeah.
Yeah, some did that.
I never done that. What I try to avoid upon exit, right? You're one in, one out. I try not to hydrate my main wound. And it works most of the time, but I do hydrate my left wound, second port, because there's the active, my primary instrument is. So I hydrate that wound because the wound leaks most of the time. Need to hydrate, but main wound is okay because you are taking care of the wound. You did a good wound during Phaco. You don't you don't damage your wound. You hardly even move. Your Phaco Pro or your IA Pro is only one in, one out. Then that's it. The friendliest, be friendly with the wound, I suppose.
Considerations to actually be taught during this. If your main wound is small, yes, with minimized manipulation, minimal stromal hydration is needed. But when you are in the beginning stage and you are using like a 2.75 and you are stressing on the wound, I would still advise the wound to be hydrated. Okay, I do at times whereby at the edge of the main wound, hydrating it is not sufficient to maintain the stability. I do personally hydrate sparingly the central part. Okay, but bearing in mind there will be more anterior. Okay, I don't go further in because that is just that little boost to actually make it really watertight. Now I implant a lot more plate haptics IOL. So the injector of the cartridge sometimes is not that really slim as compared to the C loop or the J loop IOLs. Yeah. So sometimes when the unfolding of the IOL, okay, the wound may tend to get stretched a bit. So I do find when I insert plate haptics, I may need to actually just pump the central bit a bit more. But I just go at more superficial. It's not like the deeper to stromal wound hydration.
Thank you. Okay, then what would you suggest for for best wound construction for a best wound healing? What is the characteristic of the wound?
Aziz, that's your answer.
Best wound healing.
That is on hydrate.
How to answer this? Okay.
Best wound healing.
Best wound healing. I think little damage. You
The
shouldn't.
best wound site for the best wound healing. Yeah.
You shouldn't.
Size.
Okay. Perfect wound size. Of course, it's small, but I don't do small incision surgery. 2.75 is enough for me. I think the key point is you don't stress your wound too much. You don't even create striae during your CCC when you create CCC. Little and minimum possible damage to the wound, then it will heal good. Okay?
How about the site then?
Type 1.
It's a clear cornea, but from what we know, it should be just above the limbal vessel. For that, you can see that. That minimal bleed, and then that actually promote healing.
Nazra, if you want a measurement, okay, measurement is actually arbitrary to everybody. So the teacher said if you have a wound size of not more than 1 mm length and of a trapezoid size, when you did your dweep planner, you will have a very good wound closure and wound healing. I think that's
Very
about it.
subjective.
Very subjective.
Yeah. It's also multifactorial in one's surgical career. Once you get good and good and good, you will do refractive cataract surgeries. So at that juncture, sometimes there will be underlying corneal astigmatism that you need to address. Okay, and in those instances, a corneal incision that can address your astig would be 2.75. So then you wouldn't opt for a smaller wound, right? But in other cases where the underlying astig is negligible, and you wouldn't want to induce a lot more astig, so you would go to a smaller wound, astigmatic neutral according to the patient's keratometric reading, okay, rather than a place where you prefer. So it's really multifactorial, but I agree, I have to concur with Dr. Aziz that minimize tissue manipulation is the key. So if you do not manipulate the tissue, everything will just be, where it should be.
I want to add one thing before. I think this is often mislooked. People overlook this, the setting of the Phaco, because I've seen cases where the surgeon is actually operating with 100 Phaco power, 100 torsional, is high power, and didn't realize that it's actually very, very damaging to the wound because of the heating. And I've seen, even though it's rare, nowadays it should be rare because our machines are all developed. But bear in mind that your setting, you have to look at your setting. You can't be doing Phaco with 100 power most of the time, especially when you keep pressing your foot pedal down. And because I've seen lately cases of corneal burn because of high Phaco power. We didn't know what it was. To keep leaking. Then we investigated. Actually, the surgeon was actually using very high Phaco power, right, throughout that surgery. So you have to also look at your setting, Phaco setting. You have to use minimum Phaco setting, minimum power.
Okay, before we move on to CCC, I will open the floor for any question from the participant. And one more thing. Okay, Dr. Aziz don't use iris depositor. All right. So any other panels from the floor that can actually tell us how to correctly, properly use the iris depositor to reposit the iris? I was taught to actually reposit from like horizontally. It's gently done by the surgeon, I said. But and any tips from Dr. Azura, Dr. Zaira?
My tips is actually the angulation of whatever instrument that you want to represent the iris. Okay, if the iris prolapse is very minimal, so the iris is just abutting the cornea wound, I wouldn't bother to actually represent it as an extra step. Okay, let's say the next step is actually IA. So I would actually just slide my IA, but the dimension of where that probe is really crucial. So in the earlier videos, okay, what the trainee does, correct approach, I would do the same, okay, with that kind of mild iris prolapse, but I would have addressed the IA probe. Okay, let's say this is the iris prolapsing, rather than attacking here and trying to push. Okay. So I would just aim to be on top of the iris and over just and here is my anterior flap. So my probe would actually be nearer, Okay, there's nothing separating the anterior lip and my probe. So when my probe slides, most cases, this iris will just follow. Okay, in my in my experience with mild iris prolapse, that can do the job. If let's say it is actually more than that, okay, I find that injecting viscoelastic is not the way, because you are just creating a more a higher intraocular pressure that would actually make the iris prolapse worse.
Very minimal.
Yeah, so basically you just inject, because AC sometimes can be very shallow with the iris prolapse. So I would inject a little bit of viscoelastic through the side port, okay, just enough for a way that any instrument can go in nicely, but I would still be on top of the iris. Dr. Aziz showed a great trick of how to go in, okay, from the other side port. Actually, that is going away from the weak point. So now your big weak point is this highway, okay? So if you go in, a lot more will come out. So basically attacking it from another wound is actually fantastic.
Yeah. Just to add in with correction a bit, I don't use iris repositor because I hardly do ECCE. If there's iris prolapse in ECC, I would do using iris repositor. That's the correct way to do. So in Phaco, because the wound is minimum. So as Azura said, it's very little there. You just make do or whatever that you have. I normally do using IA probe because it's blunt and it's rounded edge as compared to your iris repositor. Is sharp. It can damage the iris even further, right? Zainal, cakap apa?
Okay. Since Dr. Azra and Dr. Aziz is not fond of Aki, but I'm a person that fond of Aki. So iris depositor is my friend. In my iris prolapse in Phaco wound, yes, you can actually meddle it with your Phaco probe or your IA probe. So it's easily deposited back. But sometimes when you are actually inadvertently made a uniplanar wound, okay, because of movement of the eye or anything, so your iris prolapse is not minimal anymore, okay? Actually it's quite difficult to handle this type of iris prolapse in a uniplanar wound. So this is where I will actually introduce my iris gently from the wound and deposit it gently, and I will actually put some pressure of minimal viscoelastic, so actually my iris will actually rest a bit more in the anterior chamber. So when I introduce my probe without starting my irrigation first, to make sure the iris is not prolapsing back. When I actually managing putting my probe nearly to the viscoelastic area that actually I've been injected, I'll start pressing my second step. So that will make sure that I can actually maintain the iris in position.
Okay. Any question from any participants? Or we move on to CCC.
Wow, collection, no?
I think we leave the PC rent later, right? Complete hydrodissection. Right. I think when Dr. Azra said the imaginary size of CCC, yeah, the imaginary size, is it based on the pupil or is it based from the cornea size?
With time, okay, no pressure, okay. So I'm sharing my experience. Okay, I'm old already, so no pressure. So in the beginning, okay, as long as you get a central, symmetrical, adequate size for a safe phaco, okay. So sometimes it can be like a bit big, okay, 6 mm, okay. So How would you know that it is actually slightly bigger? So after your IOL implantation, you know that the age of your optic is usually 6 mm. So if you see that the equator of your IOL is actually just quite similar with your CCC size, you know that, okay, this is a little bit big. You would aim for it to be slightly smaller in your next cases, okay? When you have been doing this over and over again, then basically, I think what helps is operating in the small beam, light beam, rather than a diffuse beam. So you know exactly that the patient is looking at the light, okay? I advocate this to all my previous trainees to actually try and operate on that smallest beam, yeah? Because that somehow would actually give you a guide of patient centration. Though it may not be very accurate, okay, but the visual, my centration is the patient's visual axis. So it doesn't matter really on the size of the pupil, because size of the pupil can be so variable, okay, pharmacologically, underlying ocular comorbidities and so on. So I would have that size in mind, okay, and with time you would tend to actually see, okay, this 5.5 would be how far from, okay, the age of very well dilated pupil, or how far from the age of a mid dilated pupil, okay, how far underneath the age of a poorly dilated pupil, okay. You get the hang of it as you go along, okay. So for beginners, as long as you get a safe, because you want the surgery to be safe first, you cannot have a so ideal CCC that you think is ideal, but it's a bit smallish, and then have problems with grooving, with cracking, and so on. Because in Phaco, it's a domino effect. You get one wrong, and the rest will be wrong. Okay. In the hands of a more experienced surgeon, okay, of course, with good Phaco power control, okay, even in a small CCC, Dr. Aziz would be able to hold the nucleus, okay, and do his cracking. But in a more novice surgeon, you would want that view of being a bit I mean the surgical view, the clear CCC out of the way to do your cracking, to do your sculpting more efficiently. So all this will evolve with time. Okay. I think I leave it at that for the moment.
How about when you run a CCC when it's about to extend? Do you have any tips on how to rescue?
Okay, so I it was really my intention of putting the last surgical tip as being one step ahead all the time. Okay, so we have to move on. Okay, when you do CCC, you have to be a bit of a multitasker. So your eyes, you train to look at the edge of the tearing part. Okay, but your hand is forever ready to actually counter the direction of pull. So let's say the CCC is going, it's extended, okay? You want it to come this way, but it goes that way. So you know that it's going that way, and your hand will start to actually pull it to the center. So you change the vector of pull, okay? So in order to get that extension coming back to an area whereby you are able to visualize, and then complete it in the usual manner. So if let's say the doing the CCC is like a spinal reflex, no, I must turn this way, okay? So then you would miss that crucial point to change the vector to the center, okay? Once it is already near to the equator, okay, no matter how much you pull to the center, usually it's not a winning game, okay? So the take home message is you have to be one step ahead. The moment you see it coming not in the way that you would want it, pull it to the center, pull it to the center. and never give up. It will come back.
Never give up. Okay, right. Okay, so this then I will ask this question to all the panel about this on how you do CCC on a hyper mature cataract, on a intumescent cataract with a high intralenticular pressure. So I think each panel has their own way of doing it. So I would like to have all the tips from all the panels.
Siapa dulu?
Zai, you start first.
Zai nak cakap sesuatu.
So actually, I got a bit of technical tips of how doing a good CCC for a beginner. But actually, I will keep that during my last presentation. Okay, so to make it more exciting. So to answer Dr. Nazra's questions, in my hand, if I have a hypermature white cataract with a high intraocular pressure to begin with, so the first thing I will decide that about my viscoelastic density. Okay, I will prefer to have a heavy viscoelastic density so that it will tamponade my anterior capsule before I start poking the anterior capsule itself. So when the anterior capsule will be dampened down a bit, if you have a milky type of hypermature cataract, so with a small poke, I will start it with a cystosome first, because I know that by poking once, this milky cortical matter will come out. Okay, it will express out. So I will actually aspirate a bit of this cortical matter, and if it keep on coming out, I will aspirate everything that actually inside the anterior chamber. So, and then visualize back how actually collapse the anterior capsules itself. Okay, then we try to go back to the anatomical position of the anterior capsules or cataract itself. Okay, we try to fill up this anterior capsule gently with a minimal of viscoelastic, but bear in mind not to inject too much, because they will definitely drag the anterior capsule away. So when you have this type of situation, you have a stable anterior capsule in a stable anterior chamber, then you can continue your CCC in a usual manner. And bear in mind, in a high pressure white cataract, your CCC is actually easily to be extended. So as Dr. Azra said, you have to be a step ahead to predicted what will happen if your CCC start to run. Okay. Aziz,
Okay, as I presented yesterday, I don't normally aspirate the cortex because I believe that the needle itself will create that, the vertical or straight line run of CCC. So what I do, I just use my usual ways, Utrata. I turn it quickly and I press the nucleus down instead of aspirating, because what makes it intralenticular pressure pushing from inside. So I keep pressing the nucleus down, or I disturb. There's a layer of cortex pushing it outside into intumescent cataracts. I would just disturb that and press it down, basically. So and continue with the CCC safely.
You mean by Dr. Aziz will actually just do a quick one and then press at the same time pressing the center of the nucleus? Is that how?
Yes, whatever exposed, because your initial tear is small, your turn is small, so it just whatever exposed there, you just press it down. Keep pressing down. It's quite safe.
If your cortical matter block your view of your capsule, so how do you tackle it?
OBD lah.
OBD, disperse it away.
OBD, disperse it away, and quickly. The idea is to quickly do it.
Aziz is Superman.
Before it extends.
it's so hard to multitask, to do it fast and press it down and then to, you know, make the milky thing come out and then you blocking your view. Oh my God.
Time is very important.
Yeah.
Yeah, do it quickly lah, before. Don't allow the milk to come out. Just do it quickly, then just finish it off.
Maybe for beginners,
Yeah, beginner, I
it's a bit
advise.
difficult.
I advise just don't do it until you get your hands refined. Don't perform stunt, and until you get your hands stable, you know the foundation right, then you do that. That's my advice.
Azura?
Dr. Azura, any?
I nowadays, okay, I practice in the private practice, so I cannot take risks. So I usually in intumescent dense cataract, and I see more now during the MCO because of your reduced workloads, okay, for OT. So they come for private and they come like mature and intumescent, okay. So basically for all these cases, I would go in, I don't bend the cystotome. So it is actually just a straight half-inch 30 gauge needle, okay, that we use for intracameral and so on, okay. So basically mounted to a 1cc syringe, okay. After Vision Blue, I don't have the luxury to like choose my viscoelastic, so whatever that is present, okay, but adequate viscoelastic, and I usually reserve my own Utrata, especially for dance. Why so? Is so that you know that there's nothing wrong with this Utrata forceps. The tips are sharp, it's well aligned, and it can grasp what you want to pick in the eye. Okay. The last thing that you want is an instrument that would actually sabotage all the things that you want to do quickly. So in these cases, then I would say, okay, I would want my Utrata. So basically after aspirating, so when I go in, okay, it's not trying to prick, okay, it's just one stab wound and aspirate. So no multitasking, Nazra, it's just like stab wound and aspirate, okay. So what I see would actually be some crumpling of the anterior capsule. I want that, okay. So meaning the intracapsular pressure is already, I'm winning, okay, because my intra chamber pressure would actually be would be more than my intracapsular pressure. So then I quickly take my Utrata, and yes, the trick is very fast. Not just fast, but very fast, okay? So you do that CCC, the same technique that you are used to, one step ahead and complete it. This is not the case whereby you pick and then see and then re-grabs and grabs again. No, the trick is fast and furious. You just go and complete it one round, okay? In the remote instances that it extends and you see an Argentinian flag, okay? Still, you be quick and counter, come to the center. In most instances, it hasn't gone posteriorly, okay? But it will do so if you get panic and you come out of the eye trying to get viscoelastic and so on. Most likely your viscoelastic will be enough, okay? What you need to do is just be in the eye. If you see a deep anterior chamber, you have enough viscoelastic for you to complete the task. Just be fast and pull everything to the center. You've got nothing to lose. If it has gone posteriorly, you would see a tilting of the lens. If the lens is still where it is, similar plane, you just pull everything to the center. So what you will end up is actually a big CCC, but still anterior to the equator. And how would you know it? When you introduce your Phaco probe, things are still stable, and you can rotate and you can do everything. So your pulse rate should be back to how normal should be, and just continue the thing. Inshallah.
I would actually put more visco at the pupillary margin. I got tamponating the pupil so that it doesn't extend. But doing it really fast and furious, yeah, I think my heart beats faster than that. Okay. All right, now we move on to hydrodissection. Right, Dr. Zara, how do you actually predict PC rank when doing the hydrodissection and then the PC suddenly give away? What will be the signs of that?
Okay. The early signs when you anticipate a PC RAN when you do the hydrodissection is when you have a sudden deepening of your anterior chamber and you have a momentary dilatation of your pupils. It's a snap pupil. Okay. Then you should suspect something. Okay. You might miss the early sign. Okay. Then you continuing your phacoing. And when you start phacoing and you can started realize that your lens start to tip sideways. Okay. So that's where you have to anticipate that you already embarked to a PCRAN problem.
And then to test for how enough is your hydrodissection. Sometimes it's kind of annoying to see your trainees keep on injecting here and there, injecting, and then they test, rolling the nucleus. You're so worried about the zonium, right? So
Yeah.
how do you actually do a proper one?
I usually stand by there looking at how they are doing it. Okay. I actually make sure that, okay, I give you only 3 times to inject. Okay, do it properly. If you cannot rotate your lens, then never mind, you do your sculpting first and see how whether you can rotate after that. If not, then you can actually go in again to further hydrate the the hemisphere of the lens, because the first trench, if you're able to do and you can crack, but if you cannot rotate, it means that some fibers still actually attached to each other.
I don't nak jawab ke? I only do at two sides, 3 and 9 o'clock, 2 sides. That's it. Then come out. I think after that, the task will be completed by your rotation. I don't really do, let's say, if it doesn't rotate, right? Some people traditionally teach that you need to rehydrate. I don't do that because I believe whatever leftovers of adhesion, unless it's polar or capsular fibrosis behind that, it will move. It doesn't move because of, as Azura mentioned earlier, right? I use small light that helps me to centralize the eye and puts the eye in an anatomical position. That helps to actually make sure the eye is flat. The AC is in anatomical position before you actually rotate it. The failure to rotate most of the time because its eye probably is being rotated down, pushed down, then the trainee was actually rotating it when the eye is pushed down. So it has to be in anatomical position, and using your Sinski or your chopper, you can actually dial. Yeah.
So you don't really test whether
rotation also,
right, Dr. Aziz?
Apa dia?
You don't really test whether it's the nucleus is already loose.
I don't test that. I'll just assume it is rotatable. Unless it's polar or dense cataract, I don't do it. I don't do hydrodissection. And others, I believe more in your physical rotation to get rid of those whatever adhesions leftovers.
Right. Okay. So we move on to the Phaco technique. Right. So do you crack first or you do rotate first? Which one is correct? Is there anything wrong? Cracking or rotating first?
Nak jawab siapa? Siapa jawab?
Any of the panels maybe would like to answer?
I will rotate
Tapi
first.
kalau Phaco chop kena rotate first.
You rotate first, eh?
Because if I don't rotate first, let's say I crack, I groove, I crack. So of course, in good hands, you can actually rotate after that. But when it is fully cracked, it becomes two segment, right? For example, it is not in the position is probably one up down. It is not in the flat position. You know, the how do we say that? Is the alignment of the nucleus is not there anymore for you to rotate. Good hands can still rotate, but I make it a routine to rotate first. Rotate and crack, it'll be easier. No harm to rotate. Some people believe that may cause hemolysis, but when you do it correctly, using a correct instrument, correct alignment, correct patient's position, that doesn't do any harm. In fact, it does. It will do better. It will give you better benefits. I mean, you can actually remove the segments better later.
The maneuver have to be correct because for beginners, they are not actually rotating or dialing. They actually vertically pressing. That actually make the zonule weak at the end of the procedure. Instead of they are dialing laterally, they actually press and then turn.
There's the correct balance between touching, pressing and dialing, right? So they cannot it down.
Yeah, press it down.
I would just like to add that for trainees, basically, I would advise a complete hydrodissection. It is a very straightforward step. Okay, once you establish the best stereopsis that you have, to actually focus on where the anterior capsular plane is and where is your tip of your Rycroft is, and just go underneath the anterior capsule, okay, and inject, okay. So once that is done and you see the wave, okay, and then pass midline, okay, it may not be a complete one, and you could just go to the other place that is comfortable to you, usually about 180 degrees apart, okay, and just do one more and it will get completed. What we meant by rotating, okay, is just a test of dialing, maybe 1 or 2 clock hours only, to see that the things are okay. Okay, it is not rotating a lot, okay, because it is, bear in mind that the nucleus is big, okay. If you rotate much, then there will be stress on the zonules. It's just to see that if you are confident, then yes, you do not need to dial, okay, because if you know that you've gone there and this is just like a double action again and you repeat it, and that is why certain people don't dial, okay, and they proceed away with cracking. But whether to crack or rotate, it all depends on your Phaco technique. So basically, for a stop chop, okay, Phaco chop, so I don't rotate. So we scalp, we crack, and then I rotate, okay, because everything is still within the capsular bag. The difference is just that it's cracked into two hemisphere. Yeah. So if you go and the correct method of dialing, okay, everything will just be rotatable within that capsular bag. So like Dr. Aziz, because his technique is slightly different, so he needs to rotate first, okay. But I think the crucial point is that for rotation to be safe without any stress on the zonules, hydrodissection has to be super efficient. That's the take-home message.
Okay, then I do chop, but I always have difficulty doing very soft cataract. So then I would like to ask tips from the panels on whether I should divide conquer or I should hydrodelinate or I should actually hydrodissect the segment into the AC and then only I vacuum.
Sama lah dengan.
Okay.
I also buat sama dengan you lah, Nazrah. I hydrodissect. But I'll make sure after that, I complete it with hydrodelinate to make sure that I tumble up my nucleus, leaving out my epinucleus. But sometimes in and out, I have difficulty actually getting the epinucleus out at the end of the surgery.
Perhaps soft cataracts are not meant to be chopped. So it's enough to actually just crack into two, and with high vacuum you engage it and you can just aspirate it, because literally it's just like a phaco aspiration rather than a phaco emulsification. So it's just like a lens aspiration kind of thing. And if you look at the parameters, there's hardly any phaco power. What occurred during that time is just aspiration through the phaco tip. Yeah, I am actually in the process of developing a new so-called Azura technique. We'll save it for next year for soft cataract.
Because soft cataract is something that the trainee will ask every time. How do you do
Yeah.
soft cataract, doctor? How do you say soft cataract? But I
So,
come
yeah,
up with
I do
for them.
a number of refractive lens exchange for presbyopia in their correct age, suitable candidates. Yeah, never put me out of context. So in these sort of cases, because we want the corneal healing to be super fast, and they don't have much nucleus matter to start with. Okay. So basically, what I do is I do a proper hydrodissect, and then with a little bit of hydrodelineate, and then instead of just popping out the nucleus, I hydrodelineate at the epinuclear part. Okay, and then I be horizontal just in the AC. Okay, because things are super soft and super loose now. Okay, be just flat and just zoom in, so everything will just come to my port in a circular motion, and it's just a phaco aspiration. But I would save that for the intermediate or advanced phaco workshop rather than a basic phaco workshop.
Right. How about hard cataract then? Is it better to chop or is it better to divide and conquer? This is a question that the trainees always ask.
Anything that works best in your own hands. Okay. While I feel phaco chop is good in my hands, if let's say a lot more power is used, okay, because you end up not chopping, okay, it's like a partially chopped lens, and the holding power is not there, so repulsion keeps on coming in and out, so that's not good either. So in those cases, in more junior hands whereby your foot pedal control is still not yet optimized, it's going to get there, but you're still learning, then I would concur that divide and conquer is the best method. Okay, at the end of the day, what matters most is the effective phaco time achieved for that particular case. So anything that works best in your hands.
Any other input?
Just to add, Nazra, agree with Azura. When do you see me chopping all the time, right? But there are cases where I can't chop. I do divide conquer. Halfway through, let's say if I can't find, of course, NS2 plus hard cataract, you can actually easily chop. But there are cases where you encounter in the middle of your phaco, you can't chop. Right? You can't hold, you can't. You just do divide conquer. You just groove and cracked it. So it's wrong to say that you're chopping all the time. Yeah? So I do divide conquer as well. Yeah? But that comes naturally as you do it. Yeah? All right. Ada apa-apa?
And then removing last segment. Okay, tips on the removing of the last segment. Some might feel, hey, you need to actually protect the PC with your second instrument. Some will actually take out the second instrument. I noticed that Dr. Azura does that. Dr. Aziz doesn't do that, but I think they is actually putting the dynamic in the best way to remove actually the last segment, so that you don't get the surge, and then the PC will not actually come up.
Yeah.
Yes,
Sorry?
how to measure
Okay, I believe in doing last segment. I don't change it to the last segment. I just do it once and then just do it fast, get away with it. The most important thing is just to make sure your wound is intact. You have to understand your Phaco dynamics in surgery. Then you understand. There's no point changing it to the last segment, lower setting, because there's no need to. As long as your wound is stable, your irrigation is correct, you're not withdrawing at any point your Phaco probe, you just make sure your irrigation, the tip is in, and that's it. You finish it quickly. Okay? There's no reason for the PC to come up. That's the my belief, unless your wound leaks or you withdraw the Phaco probe outside the wound or within the wound when you are doing Phaco.
Okay, as for me, you have to know your limitation, okay? Because you yourself, who you are and how you're doing things. Okay, if from the start you already predicted that your procedure is not so stable, mostly you will get a problem while actually engaging segment. So as for me, if I anticipate things to happen at the end of the surgery, I'll go to a last segment mode and then do it a bit more careful. So I lower my parameter actually for my last segment in certain cases. If you are not expecting, thinking ahead, then you have to be a bit faster taking out the last segment. Zura?
With time, okay, everybody shall learn the Phaco dynamics throughout the Phaco session is actually controlled by your wonderful humble foot on the foot pedal. So basically, why Dr. Aziz and I do not have last segment setting in our setting is because we do it on our own by our right foot on the pedal. So although it is actually in the segment removal mode, we actively change the amount of vacuum, the amount of power needed by titrating that from the foot pedal control. Okay, of course, among the beginners, that is done for you by default in the last segment removal. Okay, so yes, initially you can start with that, but please realize that you can also achieve that in the same mode by moving. You have to explore what your humble foot can actually do down there. Okay, in order to create a lot of happenings, efficient things inside the eye. Yes, partly is the hand, is the pivoting technique, but with time you realize that mostly is done by your foot.
We shall take questions from participants before I ask the panels for their last and precious tips before we move on to another lecture. Any question?
Dia tanya budak-budak. Questions.
Oh, banyak question tu.
But I think we leave the PC run later.
Phaco
Okay,
setting,
down.
Phaco setting, Nazra, let them go to their YouTube channel. YouTube channel, there's the settings, setting hard cataract, soft cataract. They look at the parameters and compare the setting from there. Right?
Okay.
All right. So we skip that. So
Please
setting can
subscribe to
get
the
from
channel,
YouTube.
right?
My YouTube, our Selayang YouTube channel.
Okay, this one also skip. I will explain in my lecture afterwards. The center hydration.
Moderate to mild to moderate goitata. The key to do this is fast surgery. It depends on what type of surgery and what type of cataract you have. If it is hard cataract, you still need to do with high setting, but you have to, there's no it's very subjective. There's no hard and fast rule for mild to moderate goitata, but you try to keep it low setting, low Phaco power, low irrigation. But with hard cataract, it's impossible to do that with low setting. The key to do it fast. You chop it can do it fast.
Do it fast, but what is most important in a patient with Gatata, the preoperative prep for the patient is very important. So whatever you encounter intraoperatively and postoperatively have to be understood by the patient. Then you actually have a safe situation while handling this type of cataract.
Adequate protection of the endothelium is very crucial. So at any point in time, okay, please inject in this sort of cases, then request for a viscodispersive kind of OVDs to actually protect the endothelium. So use it, to coat, and if you need, just prior to that, and just, inject again.
Next, beginner, Phaco job or Jivat Conquer. different opinion. Zain nak cakap?
Ideal technique is okay. It depends on your teacher. Okay? Because if you start with divide and conquer, later on, of course, you want to start chopping. Okay? Soon or later, your divide and conquer actually will be modified with with time, because you won't actually stick to divide and conquer forever.
I think the divide and conquer actually taught us a good pivoting technique during cracking. That's a very good one. And later when they chop or whatever, that pivoting technique remains.
Okay. What would
Withhold medication contributes to iris prolapse. Well,
sometimes we did if patient on any prostate medication, we will ask them to withhold, but we're really not sure how effective if we actually ask the patient to stop taking the medication for about, because it still happen intraoperatively.
it's still there. It's about your technique of doing surgery. Don't enlarge your wound. Let's say you have iris prolapse, manage it properly. Never extend. For example, when you want to insert IOL, for example, you want to extend. So you invite trouble. That's it.
So I don't normally stop any medication. Okay, to me, the risk outweigh benefit of stopping any medication if it's just for Phaco emulsification. That being all medication, inclusive of blood thinning agents or tamsulosin, be whatever it is. Yeah. So I believe that our surgical modification techniques should be able to do the job. I think one thing that we should add is, okay, in the remote instances that the wound is a bit big, inadvertently becomes bigger than what you would want, and iris prolapse occur, it's quite all right. Just suture the wound, okay, and the AC would be more stable, and you can proceed without further iris prolapse. I think the next one we have answered, so I do not bend the 30 gauge needle. I just poke it in, okay, straight, and be ready to aspirate it quickly. Yeah.
I think that we answered every question, Nazra.
Yes. Right. Okay, before we call it in, maybe and all the panels can share one last tip for all the participants.
Last tip Last tip.
Apa lagi?
Apa last tip lagi? Precious tip.
Tips yang paling best sekali for the beginner.
Tip yang paling best sekali ya.
Best tip.
Okay. While all this may sound a bit too overwhelming, okay, so please know that all of us, there is a first step to everybody, okay? So basically, know your limit, okay? Never give up. At one fine day, we will get old and you guys will be operating on either my eyes or my spouse's eyes. So things will come naturally, okay? But know your limits, okay? Learning never stops.
Sorry?
Azura and Dr. Aziz, Dr. Zaira.
Sarah dulu.
What's that? Okay, know your limits is very important. To be too confident also is not good. When as a beginner, if you're too confident, your teacher said you are doing it wrongly, please accept it, okay? Because you are still at the learning stage. Don't be too stubborn saying that, no, I'm doing it right, I'm doing it right. Know your limits, try to get all the good tips, okay? While doing your, with time, you'll be a good surgeon.
I think
Right?
I see it or overview lah. I'm a public health person. What I see from this Phaco learning is you have to be clear with your objective. Your objective is you want to learn in order for you to be able to teach others, because teaching learning stops when teaching stops. So when you become a full-fledged Phaco surgeon, you still need to teach because you are still learning. I'm still learning from my trainees. That's how you look at it. Yeah? You have to share with others. After that, you share with juniors. Teach and teach and teach. That's how you learn. Yeah, that's it.